Hi, I'd like to thank the organizers for choosing this talk to showcase at this workshop. And first off, I'd like to acknowledge that this research took place on the unceded ancestral and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, which is located in Vancouver, BC. So with over 66,000 people living with HIV, there is a gap between the lifespans of women living with HIV versus men living with HIV, with a gap that is slowly increasing with time. That is around 10 or about 10 years. Women living with HIV are also experiencing a lower likelihood of survival compared to men living with HIV. And the combination of HIV, antiretrovirals, and environmental factors contribute to immune activation and chronic inflammation, which results in the accelerated aging phenotype we see. This project investigates sex differences and how they contribute to immune activation and chronic inflammation, as well as the associations of other persistent viral infections other than HIV. So this project looked at 7 other viruses, including cytomegalovirus, herpes simplex virus 1 and 2, Epstein-Barr virus, human herpes virus 8, also known as Kaposi sarcoma virus, and hepatitis B and C. So these viruses are all associated with either a marker of aging, such as leukocyte telomere length, or age-related diseases. The prevalence of these viruses are higher among people living with HIV compared to the general population, and the transmission routes include bodily fluids, sexual transmission, as well as blood products. Common associations of these viruses, to orient ourselves, is congenital CMV, cold sores and genital warts for HSV 1 and 2, mononucleosis for Epstein-Barr virus, Kaposi sarcoma for HHV8, and severe liver disease for our 2 hepatitis viruses. There's currently no vaccine or treatment available for the majority of these viruses, except for hepatitis B that has a vaccine. So this study took place in the KARMA cohort, which is a pan-Canadian cohort. However, the majority of the adults were recruited in Vancouver, BC, with children recruited across Canada, including at sites at Ottawa, Toronto, Montreal, and Vancouver. The data collection for this study occurred between 2008 to 2021, and we have around 376 individuals whose serology data we collected for all the 7 viruses previously mentioned. And with the additional plasma available, we have around 296 participants included in the study. If we look at the demographic table, I'd like to emphasize that we also purposely recruited controls that were sociodemographically similar to those living with HIV. So here we see that there's no differences between our females and males in terms of age, tobacco smoking, ethnicity, education attainment, or household income, and same with our people living with HIV. And it's important that in this cohort we have in this sample we have 296 individuals, and the ages range from 1 year old all the way to 76-year-olds, and it's all well balanced throughout. If we look at what viruses these individuals have, so each bar is an individual and we have increasing age. And on the top we have female participants, and on the bottom we have male participants. So we can see that there's a higher prevalence of CMV, HSV2, and HHV8 in female participants compared to male participants, regardless of HIV status. If we segregate this by HIV versus controls, we can see that people living with HIV have a higher prevalence of CMV, HSV2, and EBV in this cohort. We then proceeded to measure 4 markers of inflammation. 3 of them are related to gut inflammation. So we have the intestinal fatty acid binding protein, which is released in our enterocytes when there is intestinal damage. We have reg3 alpha, which is elevated levels are associated with intestinal damage. And we have liposaccharide binding protein, LRBP, that binds to the bacterial lipopolysaccharides. And then we measured soluble CD163 as well within this cohort. And we measured this through mesoscale discovery, which is an ELISA-like assay. So first off, we saw that within our participants, females univariately is associated with lower levels of inflammation in all the markers that we have measured. If we look at HIV segregated, we see that HIV is only associated with an increase in IFAB levels and not the other three markers measured. Now, if we look at just simply the number of non-HIV virus an individual has, and not accounting for what type of virus, we can see that having a greater number of non-HIV viruses is associated with higher levels of IFAB, Reg3 alpha, and soluble CD163, but not LBP. However, if we segregate this by sex, we see that an increasing number of non-HIV viruses in females is not associated with an increase in any of the inflammation markers. However, if we look at the males, with an increasing number of non-HIV virus, there's a strong increase in all of the inflammation markers measured. So we proceeded to also look at the segregation based on age. And in the black, we have the overall Spearman's row and the p-value for all participants pooled together. And then we have the female row in pink and the male row in blue. So here we see that for IFAB, if we pool everyone together, there is an increase in IFAB associated with age, with an increase in age, but we don't see this in female participants, and so this is likely driven by just the male participants. We see the same thing for Reg3 alpha. We see something similar for LBP and soluble CD163. So increasing age is associated with increased level of all markers of inflammation, but we can only see a slight association with age and Reg3 alpha in females. If we look at these, this multivariate model, and we can kind of look at the associations of individual viruses while controlling for sex and age, we see that for IFAB, female sex is independently associated with lower levels when controlling for all other viruses, including HIV. And we can see that HIV status is independently associated with an increase in IFAB. Age is associated with an increase in IFAB, and HHV8, so that Kaposi sarcoma virus, is independently associated with a slight decrease in IFAB levels. For Reg3 alpha, we see something similar. However, its CMV alone is associated with an increase in Reg3 alpha levels. For LBP, only female sex and age. Female sex is associated with a decrease, and age is associated with an increase. And finally, for soluble CD163, female sex once again is independently associated with a decrease. Age is associated with an increase. CMV and HCV positive serology is associated with an increase in soluble CD163, but not HIV. So here is a summary of our multivariable results. We can see that female sex is independently associated with a lower level of all markers of inflammation that we measured. Age is associated with an increase. HIV is only associated with an increase in IFAB levels. HHV8 is associated with a slight decrease in IFAB levels, and CMV is associated with an increase in Reg3 alpha levels, as well as soluble CD163. And HCV is associated with a slight increase in CD163. So to wrap up, despite we saw in the very beginning, females having more non-HIV virus than males, they have lower levels of all inflammatory markers measured. Increasing number of non-HIV viruses is associated with greater levels of inflammation in all markers in males, but not females. Although this study can't exactly measure the direct health impacts of inflammation and the non-HIV viruses, it kind of highlights the necessity for sex-segregated analyses in all future work. So with that, I'd like to thank the CARMA participants who participate in the studies, the investigators and staff, Oak Tree team members, our lab members, and the International Women Workshop on HIV Scholarship Committee. Thank you.